Welcome to Community-Defined Evidence, a culturally appropriate approach to meeting the mental health needs of diverse populations. My name is Christina Borbet, and I'm here with my colleague, Naomi Ortega-Teen, and we're part of the Pacific Southwest Mental Health Technology Transfer Center team. I will share today's objectives with you and also outline the agenda that we're hoping to achieve together. This discussion is offered as a resource from the Pacific Southwest Mental Health Technology Transfer Center, or MHTTC. The MHTTC is a network of regional centers funded by the Substance Abuse and Mental Health Services Administration, or SAMHSA, to support resource development and dissemination, training and technical assistance, and workforce development for the mental health workforce. Naomi and I serve the region that includes Arizona, California, Hawaii, Nevada, and all the Pacific Islands under U.S. jurisdiction. As you can see, each area of the U.S. is affiliated with a region that includes technology transfer centers supporting the workforce for addiction, prevention, and mental health. During our time together, we will celebrate culture and communities and what communities do and have been doing already, programs and practices that work and are helping people. And we'll talk about how we can apply a cultural lens to the way that we look at those practices to see how well they work. This discussion is designed to be helpful for a lot of different audiences that support mental health in diverse communities, including clinicians, mental health program providers, and evaluators. Our learning objectives today include recognizing evidence on a spectrum, identifying the value of community-defined evidence, determining how to establish high-quality community and culturally defined evidence, and establishing criteria for evaluating community-defined evidence in order to identify effective mental health practices within a cultural context. Now, our agenda for today is framed in terms of questions that we often hear from the folks that we're working with. So what we'll be covering are these 6 questions and offering an exploratory frame to some of the initial answers or responses to them. A lot of these questions have much deeper answers and responses and considerations, and we want to encourage you to think about them from the perspective of the work that you're doing and the communities that you're working with. To get started, let's take a look at what we mean when we talk about culture.
Thank you, Christina. I also want to mention that we may pause a couple of times during our discussion in order to move us toward a shared understanding of terms. So first, we would like to offer our definition of culture, so we know what we're all talking about. And since we're talking about culturally appropriate approaches, cultural practices, and other aspects of culture. So for our purposes here, when we use the term culture or culturally appropriate, we're looking across the spectrum of culture, not just at ethnic and racial groups or communities, but going far beyond that. So for example, we're talking about sexual and gender orientation, socioeconomic status, age, lifestyle, and so on. And when we give examples, we may speak to a specific culture or cultural perspective, but now we all know that generally we mean culture in a very far-reaching, also very complex and multifaceted way. Let's start with the problem that we're trying to address. We know, for example, that in the Pacific Southwest, where you all are, there are core areas of unmet need, including mental health challenges, suicide and suicide prevention, adolescent major depressive episode, and serious mental illness. There are also other challenges to factor in, for example, provider shortages and availability of care, access to care, and language barriers. Much of this is actually mirrored in one way or another in national research. So again, we're talking about culture at a broader level than just racial and ethnic minorities. But since the early 2000s, there have been numerous reports released by nonprofit research companies, the federal government, and others that demonstrate substantial variation in care for racial and ethnic minorities. The findings in these reports add up to some very disheartening problems, such as inadequate access to care, including barriers such as language needs of populations being served, bias and stereotyping that can lead to inappropriate or insufficient care or less desirable or lower quality care, mistrust of providers or service institutions, leading to limited utilization of services, and this is just to mention a few areas of the problem. I'd like to just read this quote, which is, "The mental health system has not kept pace with the diverse needs of racial and ethnic minorities, often underserving or inappropriately serving them." This quote is actually from another report that also came out in the early 2000s. And these reports have been underscoring some of the underlying factors that lead to disparities, such as systems that lack the capacity to embrace diversity or to adjust to changing demographics, lack of multicultural consumer involvement in policy, planning, and research, not enough diversity in healthcare leadership, lack of bilingual and bicultural providers or culturally competent providers, and lack of appropriateness of treatment. And of course, the list is much longer than just those few underlying factors that lead to disparities.
Thanks, Naomi. And I know this is just kind of a basic overview of some of those core challenges, and I appreciate you highlighting those for us. Let's shift a little bit and talk about what are some of the approaches that we can use to address these challenges. Since we're going to be talking about how to look at effectiveness of these approaches, let's pause again for a moment and spend some time defining what we mean by evidence. At a very basic level, evidence is proof, or something that provides or is a source of proof or an outward sign. That's our dictionary definition. Let's go a little bit deeper and think about what we mean when we talk about evidence of effectiveness. If evidence is proof, then we can look at evidence of effectiveness, which it basically is proof that something is working. To demonstrate that something is effective as an effective practice, it generally means that the strategy or practice is based in a solid theory or a theoretical perspective that has been validated by research. That the strategy or practice has a track record, meaning that there are many different examples generated from similar or related practices, all indicating effectiveness and supported by a documented body of knowledge. It also means that the strategy or approach is judged by a consensus among informed experts to be effective based on a combination of theory, research, and practical experience. Once you've established evidence of effectiveness, it can be documented in things like peer-reviewed academic journals, promoted by federal agencies and other funders, for example. And then people can find it and sometimes replicate the practice, achieving the same outcomes as demonstrated by the evidence. That's a lot of jargony word. I want to go ahead and open it up and think about evidence as existing on a spectrum, right? So not all evidence is the same. We mentioned a moment ago that the evidence of effectiveness is proof that something is working, but we didn't say what type of evidence or how strong or what quality that evidence needs to be, or how effective evidence determines how much positive outcome can be associated with a given practice. Because evidence exists on a spectrum, it's based on how well it meets different criteria, different sources, or how accurate information is, for example. The credibility and the value of any piece of evidence is subject to interpretation or influences. One of the things I like to use as an example here are any given courtroom drama. So in any of our favorite shows that we watch on TV, a crime is committed, and then we have a number of investigators who piece together different pieces of proof or evidence that they bring to trial. Oftentimes, it only takes about 45 to 50 minutes to resolve very complicated cases, but that's on television. Just like on television, though, in the real world, we need to have different types of evidence, different types of proof to substantiate our case that a given practice or strategy is going to work. And we need to make sure that that's going to be working or effective with the community that we're serving. There are varying thresholds for what is accepted as quality evidence. The bottom line, though, is that evidence exists on a continuum of credibility. It's not an absolute. So let's think from a cultural lens how we can expand that evidence spectrum. Instead of looking at it on a spectrum that's a straight line, consider it from a different nonlinear shape, like thinking of the spectrum as a sphere instead of a straight line. There are different lenses and criteria that we can apply to identify evidence and then decide whether there's enough evidence to prove, for example, whether a practice is effective. Even practices that are based on evidence, even academic or scientific evidence or evidence-based practice, have varying levels of proof. It depends on the rigor and size of the research study, for example, or other considerations. So if evidence exists on the spectrum, then maybe we can think about it more broadly, about what makes practice effective. Naomi, I think you have more to say about that.
Thank you, Christina. I love the courtroom example that you used because I find it really helpful to look at another example in order to really explain things better, since this is so important to have a broader understanding of evidence, because that can really open up a lot of possibilities for our communities. So let's go back to that courtroom example. And if you're making your case to the judge and jury, you need to know the strengths and weaknesses of every piece of evidence that you share. Using this analogy, we know that evidence like fingerprints or eyewitness testimony has its place, but they're not as strong as DNA evidence. And even the integrity of DNA evidence can vary and exist on a spectrum, as we've learned over the years. So for example, the source, how degraded the example is, the rigor of the methodology used for testing it, that gives you a little bit of a sense of what we're talking about. DNA, fingerprints, eyewitness testimony are all evidence, but they generally bring a varying level of rigor. And they can come from different sources, and they can be measured and analyzed or translated differently by different people or based on different places, and they might bring with them different levels of credibility. So what is evidence-based practice? Around 1992, clinicians started to use a multidimensional approach for evaluating practices for effectiveness, evidence-based practice. Evidence-based practice is commonly defined as the conscientious and judicious use of current best evidence in making decisions about the care of an individual patient. So it looks at three areas: hard scientific evidence and best available research evidence bearing on whether and why a treatment works, clinical expertise to identify each patient's unique health state and diagnosis, their individual risks and benefits of potential interventions, and client preference, values, and needs. Let's look a little bit more at what that means. In general, evidence-based practices or programs are based on a clearly articulated and empirically supported theory. They have a detailed description of the intervention and measurement design, what outcomes were produced in what populations with what intervention, have measurable outcomes that have been assessed with psychometrically strong measures, including long-term follow-ups where indicated, have been tested in a scientifically sound way with comparison conditions, optimally through randomized controlled studies. The Society of Prevention Science has actually established standards of evidence that are used to develop lists of model programs by government agencies. And the focus of that is on quality of the research used to evaluate programs. What we've been seeing is that federally funded projects have acknowledged evidence-based practice, so there's more support and funding for it.
Naomi, I appreciate the overview, and I wanted to highlight some of the advantages of evidence-based practices. There are a lot of advantages, and there are some incredible evidence-based practices that are bringing health and healing to many communities and the people in them. Some of the advantages, well, for one, as we just mentioned, are that funders have really been jumping on board around evidence-based practices since the early 1990s and offering support and funding for those implementing evidence-based practices. They have demonstrated positive outcomes and economic benefits, and they have better accountability because the positive results have been proven. When the practice is effective, there's available funding for more widespread implementation, for materials, for training, for technical assistance, all of this ensuring that effective mental health treatments are available to the communities that we're serving. That said, we have to make sure that we have the limitations. It's not all upside. You probably knew there was a flip side here. In many cases, funders or initiatives will only listen and will only take action if a provider is proposing to use an evidence-based practice. But we know that the practice doesn't work in all cases. So let's look at some of the reasons why an evidence-based practice doesn't always guarantee positive outcomes. While evidence-based guidelines offer the advantages of consistency, predictability, standardization, and objectivity, we need to weigh the advantages and limitations to see if there's an evidence-based practice that could work in any given community. There's also a big distinction between practices such as evidence-based practice that are used or applied with underserved cultural populations and practices that are developed for or developed by those underserved cultural populations. For example, let's take a look at language. There might be a great mental health curriculum that was developed to train providers or community members to recognize signs of depression or suicidal thought, or maybe to prevent depression, but it's only in English. What if we want to use that in a monolingual Filipino community? So we change it to Tagalog. That's a start. But what about examples in the curriculum? Will the examples be culturally appropriate in this translated version? Or has it just been a literal translation of the curriculum? Can language translation alone capture the cultural interplay in the diagnosis and treatment of the condition? Can a literal translation of the curriculum capture how depression manifests and the different strategies to prevent depression in a Filipino community? Even cultural adaptation, where we modify more than just the language itself, can work, but still isn't something that came directly from the community itself. And there may be other limitations to an evidence-based practice. For example, does it take into account how the culture impacts health-seeking behavior? What about the provider-patient relationship or the interaction between men and women or older and younger people? What other limitations can you think of when using an evidence-based practice in a cultural context?
Thanks, Christina. And before I mention another limitation, I just want to add with culture adaptations, it's not just a matter of making sure that examples and programs and approaches are understandable, but also that whoever is using them actually feels like it applies to them and they're comfortable with it. And that's really what we hope for. So I just want to mention actually another limitation of evidence-based practice. And I think it's a big contributing factor to why evidence-based practices often don't work with or aren't appropriate for culturally diverse populations. Let's think about who's participating in the research that serves as a basis for the evidence supporting those practices and who's defining the evidence. And let's look at some of the key concerns. And this kind of goes back to that courtroom example. Very little research related to evidence-based practice has been conducted with diverse, underserved populations. In fact, the evidence base for racial and ethnic minorities is alarmingly incomplete. Research used to generate professional treatment guidelines for most health and mental health interventions doesn't include or report large enough samples of racial and ethnic minorities to allow group-specific determinations of efficacy. So it makes it difficult to ascertain whether currently identified evidence-based practices are best practice models for culturally diverse communities. Even though some of the research, funding for research and research approaches have changed a little to be more inclusive, there's still so much variability and a lack of adequate research involving racial and ethnic minorities or strategies in that research to effectively capture information through a culturally appropriate lens. That brings us to taking a closer look at community-defined practice and evidence, or you could also think of it as culturally defined practice and evidence. So what's the story behind community-defined practice and community-defined evidence? Around 2007, the National Network to Eliminate Disparities in Behavioral Health, or the NED, which is a SAMHSA-funded initiative, recognized that there's a lot of great work going on in communities, and they wanted to find a way to identify programs that people knew worked, but didn't have enough evidence to be considered as one of these evidence-based programs or practices. So the Community-Defined Evidence Project was born as a joint initiative of the National Latino Behavioral Health Association and the National Network to Eliminate Disparities, the NED, in association with the University of South Florida. The purpose of this was to identify practices being used in the Latino community to help serve Latino communities that maybe hadn't risen to the top of being a program that had undergone one of these rigorous evaluations with randomized controlled samples, for example. The effort identified programs that, again, that people knew worked, but just didn't have enough evidence to be considered an evidence-based program. And then the idea was to share information about those programs so that other communities could learn about them as well.
Naomi, all of this kind of springboarded to what we can agree upon as a definition for community-defined evidence practice. It's a set of practices that communities have used and determined to yield positive results as determined by community consensus over time, and which may or may not have been measured empirically, but have reached a level of acceptance by the community. So basically, this starts as a practice that's working in the community. The community defines the evidence around the practice by observing the practice over time and acknowledging and accepting that it is something that the community utilizes and recognizes benefits from. The goal is to develop an evidence base that works for and matters to the communities most impacted by the conditions, policies, practices, and programs that drive physical and mental health outcomes. And that is also one of the benefits, that it matters to and is relevant to the community. Another benefit is that the community-defined evidence becomes more widely accepted. Resources are anticipated to follow suit to scale it up, meaning to help those practices reach similar communities of culture and to better support these practices. So again, it's taking a community-defined evidence practice, building the evidence, building the proof of its effectiveness so that resources and scalability follow suit. Overall, the use of community-defined evidence allows communities to take the lead in identifying culturally appropriate measures to develop a study or a process designed specifically for their own communities and relevant to their cultures and traditions. Community-defined evidence is a set of practices that communities have accepted and have identified as effective, even if they haven't been formally measured. These are practices that produce positive results consistent with the community's or the culture's definitions of wellness. Community-defined evidence is commonly based on community beliefs regarding distress and healing, as well as on cultural and traditional practices. So community-defined evidence developed for specific underserved populations should demonstrate an understanding of the culture's impact on mental health and its treatment. Community-defined evidence practices are developed for specific populations that include strategies and/or interventions that address the cultural expression of distress and coping. Community-defined evidence also considers the perception of a specific community and its population, as well as the historical and social background of that community. CDE promotes equity by considering cultural implications in the research and identifying a solution for minoritized populations. As CDE becomes widely accepted, resources are anticipated to follow.
I always like to define acronyms again at a stopping point. So when we say CDE, we're referring to community-defined evidence. And then when we say CDEP, here we're talking about community-defined evidence for effective practice or community-defined evidence practice. So let's look at what the criteria are for community-defined evidence so we're able to establish effectiveness of these practices. One way of looking at this, and this is developed by the evaluator for the California Reducing Disparities Project, is to think of this as a three-dimensional cube. So the cube itself represents a cultural activity. And the purpose of this is to show that the context for the cultural activity is made up of what we're calling visible and invisible elements. By looking at them as a cube like this, we're sort of saying that they can't be separated. The visible elements, which are on the left side, are objective, explicit. They're objective and explicit manifestations of culture. You can see them. So basically they're how things show up in the culture. What's the activity? Who's involved? Where does it take place? But you can't really have this model without an understanding of the questions around the invisible or subjective and implicit elements of culture. Basically the way the culture wants to define itself or reflect itself rather than just how they are coming out or coming across. So different people, based on their historical and social experiences, are going to have a different conceptualization of the problem. What do I mean by that? People may look at two sides of the same problem or program or issue and whether consequences should be, for example, punitive or restorative. Let's use an example of a prison reentry program. So a survivor of sexual assault may look at prison reentry in her neighborhood, for example, very differently from family members who have been unhappily separated from each other because of prison. Same example, two very different perspectives or outlooks of that example. Let's look more specifically at some of the criteria for community-defined evidence-based programs and practices. Some of these are capacity building, raising public awareness, community outreach, increasing service accessibility, innovative engagement practices, localization of services and practices, and appropriate interventions and treatments. So these are some of the elements that define community-defined evidence practices and criteria that we can use to look at them more closely. So how do we measure effectiveness of a community-defined practice? And this is another good place to pause for a point of clarification, which is basically just to say that we recognize that all of these types of practices and models and approaches, whether they're evidence-based or cultural adaptation of an evidence-based practice or other program or community-defined practice, or really any number of other approaches, they all have their place. One may be more or less appropriate in a particular situation or circumstance, but they're all important. So we're definitely not saying one is good and one is bad. It's all a spectrum, really.
Yeah, and to that point, Naomi, I want to just highlight that we're collectively in the process of shifting our thinking about how to build the evidence for community-defined practices. Evaluation practices in general are challenging to implement, often because of funding or capacity or the smaller numbers of individuals to study in underserved populations. But communities themselves are positioned to define the scale and the scope of evaluating their successful practices. So a lot of times the language around evaluation is very inaccessible and it makes it feel like a daunting task. But if we think about the work that we're doing that we know has positive impacts for the individuals that we're serving, we know what goes into that and we know why it works. So starting to document that is a simple step towards building the evidence for the proof of its effectiveness. In doing so, there's an opportunity to focus on why these community practices are valuable, and then propose and track the outcomes that matter to the community. In order to kind of get things started, communities can first focus on a single strategy or a single practice as opposed to programs or more complex efforts. Things that could be potentially useful for broader use in your community or in other communities. Some communities have taken the approach of starting with an evidence-based practice and then culturally enhancing or adapting the program to meet the needs of different communities while collecting data on its effectiveness. There's definitely a need for culturally defined and community-defined practices in order to start evaluating them. So instead of online surveys, for example, you might consider using listening circles or observation of drum circles. We focus on solutions that we know work for demonstrating effectiveness of our practices that are culturally defined or community defined. As part of the process, it's important to document and show how strong a process there is for community change. In other words, how is this process getting from one point to another? How did it happen? Answering these questions help us build the evidence for our community or culturally defined practice. And since the community-defined practices aren't limited to clinical treatments and interventions, the community can include practices that increase accessibility, availability, and utilization of services. Since practices are validated by community members, assumptions and bias can be prevented and equity is promoted. Earlier in our discussion today, we were referencing the concept of informed experts. The idea that informed experts needed to agree that a strategy or approach is effective. With our cultural lens that we apply to look at evidence, informed experts include key community health leaders, healers, elders, and other respected leaders within indigenous cultures. I wanted to just share this particular diagram as an example of how to approach the elements for determining whether a practice is effective for a given community. This is adapted from substance use prevention paradigm, but has great applicability to what we're thinking about here. These are some of the elements for determining whether a practice is appropriate and if there's sufficient evidence to determine that it's going to be effective in your community. It can be applied to mental health, or it can be applied to other practices or strategies that you may be considering adopting. The elements here are relevance. Is the practice meaningful for the need? Feasibility or practicality of the practice? And then finally, effectiveness of the practice. As we talk about this over the next few slides, we may notice that the practice is already something that the community is doing and accepting, and therefore, by nature, pretty much already meets the relevance and feasibility criteria. So it's primarily the effectiveness part of the best fit strategy that we'll focus on. But before we get to that part, let's take a look at the first two steps.
Thanks, Christina. That actually makes a lot of sense, because if the practice is something, when we're looking at relevance, if the practice is something that the community accepts and has been doing and it's working, then it's probably already relevant to them. So really with a community-defined practice, you're starting with something that you've already acknowledged is relevant, and you've acknowledged its relevance just by the nature of doing it over and over as an accepted part of your community. You may not be used to documenting it or having to show others the relevance. You're really kind of already there with the relevance. And when we look at relevance, we have some questions that are helpful to look at and answer in order to do kind of a relevance check. Even if we have a sense already that a practice meets that relevance check, as part of this process of establishing evidence of effectiveness, there's a confirmation or rating process to evaluate the relevance of existing or potential strategies. So essentially the relevance check looks at the population, the setting, whether it's culturally appropriate, and availability of implementation materials or resources. I actually recently read, not long before today, read about an evaluation that successfully demonstrated the effectiveness of combining a traditional healing practice, so in this case it was a sweat lodge, with an evidence-based counseling model that had been designed to reduce intergenerational trauma symptoms and substance use disorder. So in the case of sweat lodge practice, since the community or culture that the practice is intended for was already implementing it in their community, they were probably able to check off pretty easily whether it's appropriate for the population, whether it's likely to work in the setting where it's delivered, since it's already being delivered there, and if it's culturally appropriate, and whether members of the culturally identified group participated in developing it. So then let's look at feasibility. If the practice or the program doesn't fit the capacity, resources, or readiness to implement, then the community or the organization within that community is unlikely to implement the intervention effectively. So just as with relevance that we were just talking about, if the community didn't find a particular practice practical or it wasn't feasible to implement, they wouldn't be using the practice already and consistently in their community. So if it is something the community is doing, let's say as an expression of their culture, such as the example we were just talking about, like a sweat lodge or maybe a drum circle, then that's why they're already doing it, because it's an expression of their culture. I recently heard of another example that isn't exactly a cultural example, but rather a community or local practice. This is in a rural community where kids there were already used to animals and working with animals. So in this case, they learned how to train horses and how to work with horses more closely, and that gave those children a sense of connection, something that was actually helping their depression and risk of suicide. Let's look at the feasibility check, just like we had a relevance check. So here, again, there's a confirmation or a rating process to evaluate the viability of existing or potential strategies that looks at whether it works administratively, technically, and financially. So essentially, we're talking about, is it feasible to implement after considering any written or oral policies or procedures of the organization or body implementing it? Are there people with available time to implement it? And is there enough money or other necessary resources to implement it. Again, chances are, since it's already being practiced in the community, these criteria or considerations should be fairly easy to check off.
So that brings us to the effectiveness question. Once we've gone through the steps of making sure that the relevance and feasibility are in place, we want to scrutinize the information to determine if we're likely to achieve the proven outcomes by implementing the practice within our cultural context. Consider the sources and the quality of evidence are important to you and to your team as you're considering options. If this is a practice that you've already been implementing, then think about what are the pieces of proof that you want to gather to tell the story about what's working. When we're doing an effectiveness check, we want to ask some of the questions related to effectiveness. Some of these are already built into our practice. For example, no adaptation is required because the practice was designed by or has already been consistently implemented by the population for whom it's intended. This is an area, effectiveness, where the strength or the quality of the proof will depend on the methods that you use to gather information and how rigorous those methods are and the consistency and the magnitude of the effects of the practice that you can demonstrate. I want to share an example. I did a co-creation of an evaluation design with the Redwood Valley Rancheria in California. And there they were interested in developing evidence of effectiveness for a youth-based program to ensure that young people had a positive embrace of their traditional Pomo Indian identity. So when we were looking at what kinds of evidence would matter, what kinds of proof we wanted to bring before the community experts to review for consensus, what we looked at was the different sources of information that we could gather and whether we could gather information about the effectiveness or the outcomes in more than one way. What we did was we put together focus groups of the young people. We did an objective analysis of the youth artwork associated with their traditional identity. And then we also tracked or just kind of kept a basic log of youth attendance at traditional ceremonial events. That's just one example of how we can do an effectiveness check and think really intentionally about what are the ways we want to measure the impact of the work that we're doing. So that kind of walks us through our best fit paradigm of relevance, feasibility, and effectiveness. Naomi and I want to take a few minutes to just talk through what are some of the pitfalls and how to avoid them. While we're talking about how to establish evidence of effectiveness, let's talk about what we've learned from past experience and what not to do, so that we make sure that the strategies that we use to measure community-defined evidence address or avoid them. The first I wanted to highlight is under-resourcing. Many communities that we serve have already been under-resourced for years. So not only do we need funding to measure and implement mental health prevention or treatment practices, but we may also need to overcompensate by either initially bringing in more support, like evaluators or trainers, for example. The other thing that I wanted to highlight as a lesson learned has to do with traditional evaluation. I want to reframe this and term it academic-style evaluation. Often, Western approaches to evaluation are not applicable or may not work as well. For example, using paper and pencil forms or online surveys in lower literacy communities with limited technology. Those aren't an appropriate fit. And this isn't just about what not to do because it's not appropriate. It's also about an opportunity. Evaluation can often feel like something being done to communities instead of for or with our communities. It doesn't have to be like that. Movements in the field of evaluation, such as community participatory-based research, culturally responsive evaluation, and equitable evaluation are shifting the way in which communities are engaged in driving their evaluation. These kinds of participatory processes also focus on building capacity within the communities. So evaluation of a community-defined evidence can be focused on how communities can move through the process as partners to identify and collect sufficient proof of effectiveness. Naomi, I think you wanted to highlight a few other lessons learned.
Yes, I'm glad I'm not the only one who has some lessons learned from these experiences. There are definitely a few more pitfalls to watch out for. For example, overgeneralizing. There can be multiple communities, even within one larger community, that have different needs and perspectives. What might work for one segment of the community or what one segment has confidence in might not be the same thing that works for another part of the community. So to give a couple of examples, we were working on a mental health curriculum, and there was an example where it was talking about hiring a babysitter, and that doesn't make sense in communities where family members just take care of one another. Or there are, let's say, peer models where we might train people who work in beauty salons or have people go to laundromats where people typically congregate for longer periods of time and may even be familiar with one another. But there might be communities where those things just don't apply. So it's important not to make assumptions that what works in one community is just going to work in another community. Then timelines. Many projects and funding cycles have firm timelines and maybe strict and clear deadlines and even penalties for being late or taking more time than planned. But the closer we get to working directly with people and in communities, the more often we need to just slow down and take time to really listen, factor in the very different ways in which people operate and move. It's important to allow time, very important to allow for time to inform the community about what you're doing and why. Why are we even talking about establishing evidence of effectiveness? And to allow time for building capacity where it's needed and definitely to gather input. So if you are going to bring in anyone, let's say from outside the community, or if you're working with a funder from outside the community, you might need time to allow for relationship building and trust building that really needs to happen in that process. And this is also true of the funder, for example. So one last pitfall or lesson learned, I guess, we'll mention is overpromising. So this applies kind of across the board. For example, if a funder, or really even the community, asks for feedback and then promises to incorporate it, but isn't really able to or willing to or doesn't have the time to do that, it's really important to think about what you're promising or offering in the beginning to make sure that you really can follow through, because that can affect things like trust and relationship building.
Well, I think we could probably spend a lot of time on lessons learned. And I want to just let folks know that if they have lessons learned that they want to share or they have kind of additional considerations that they want to talk through, our team at the Pacific Southwest Mental Health Technology Transfer Center are available to you. Naomi and I had a brief amount of time to cover the kind of basics. We went through the 6 core questions that we come across most often when we're thinking about applying a cultural lens to defining evidence of effectiveness. That is certainly not to say there isn't a lot more to unpack here. As you're kind of considering things from your point of view, we put together these questions for your consideration. But really what we mostly want you to take away as the bottom line here is a sense of encouragement, that there's an opportunity to not only select programs from existing options that may be a good fit for your community's needs and priorities, but also that you are likely well positioned to start building a case, to start gathering the proof for the practices that you're already using that you know work with the individuals that you serve. And so we wanted to just kind of give you an overview of what that could look like and where it fits on the spectrum of evidence. And we also just want to make sure that we're encouraging you to reach out if you'd like additional support. We put together a list of some of our favorite resources and tools. So if you wanted to get deeper understanding of what are the strategies, what are the approaches, the different kind of theories behind this community-based or culturally defined evidence, that you have those. We had to really pare it down. So if you want to get in touch, we can certainly offer quite a number more of resources and tools that might be helpful, and we can kind of customize the recommendations based on your individual circumstances and what you're trying to achieve. So don't hesitate to reach out. With that, Naomi and I wanted to say thank you, and I wanted to highlight a couple other pieces of information for you before we wrap up. If you'd like to learn more about any of the topics that we covered, reach out to us, and you have our contact information here. We have a number of additional resources as well as services that we can offer you. We're also very interested in learning about how we can best support your needs and priorities in this area and other areas related to mental health. So you can share your perspectives by completing an online query that we've developed. You can see the URL as a SurveyMonkey link, or you can use the QR that's on the slide in front of you, and that will allow us to learn from you about what kinds of other resources, webinars, communities of practice you're interested in participating in, and we can design those for you through the Pacific Southwest MHTTC. And finally, I want to let you know that our center is also collecting proof to ensure our effectiveness in supporting you. So we please would love your help by sharing your feedback on this session. We have a form that we're required to use by our funder, SAMHSA. It's really quick and easy to complete. And so what will happen is that it will either pop up on your screen at the conclusion of this presentation, or you will find it in your inbox immediately following this presentation. Because we are using the form required by our funder, we have not been able to update the form for our MHTTC. When you see the form, you'll need to substitute the term addiction with the term mental health, so that it makes sense for these circumstances. And our funder will very shortly be releasing the updated form. In the meantime, we're very much interested in your feedback, again, so that we can continue to refine our supports and services to be most useful for you. So that said, Naomi and I thank you. Naomi, any last words before we conclude?
Yeah, just thank you as well, and we definitely look forward to that feedback.